Good morning, good afternoon, good evening, wherever you might be. I am Dr Jahun. Today I will discuss about a disability that commonly affects children. It also affects adults, but commonly found in children. That is cerebral palsy. Cerebral palsy is a combination of two words, that is cerebral and the palsy. The cerebral refers to brain cerebrum, in which it is the area of brain that regulates the motor function, while palsy describes the paralysis of voluntary movement in certain part of the body. Therefore, joining cerebral and palsy together gives the term used to describe a set of neurological conditions that affect movement. It is the most common form of childhood disability. Cerebral palsy usually is caused by brain damage, that is, developing brain. It might happen before birth, during birth, and after birth. In medical language, we call it prenatal cause, perinatal, and postnatal. But the postnatal cause of the damage has to be between 3 to 5 years. That is, the brain damage can also lead to other health issues, that is, vision, hearing, or speech impairment, or learning disability. The brain controls all types of motor functions that allow people to live as independent as possible. Motor control can be voluntary, such as reaching out to shake someone's hands, and it can be involuntary. That is, for example, when a doctor taps a spot below a patient's knee, it will produce a reflex, that is knee jerk reflex. These are some of the examples of involuntary movement. Not surprisingly, there are many anatomical regions which involve in motor functions, but the primary one is primary motor cortex, or M1. It is the principal brain areas in which motor functions begins. M1 is located in the frontal lobe of the brain, along with a bump called precentral gyrus. The role of primary motor cortex area is to generate impulses that control the execution of movement. Signals from M1, that is premotor cortex, crosses the body midline to activate skeletal muscles on the opposite side of the body, meaning that the left hemisphere of the brain controls the right side of the body, while the right hemisphere controls the left side of the body. Every part of the body is represented in the primary motor cortex area, and those representations are arranged somatotopically, that is, from foot to leg, then to trunk, then next to arm, to hand, to face, to tongue, then to larynx. When the motor control centers in the brain are damaged, voluntary and involuntary motor skills do not function properly. This can present an array of challenges related to one person's ability to walk, to talk, or complete everyday tasks independently. The worldwide incidence of CP is approximately 2 to 2.5 per 1,000 lives, according to World WHO Organization report. And it also affects 17 million people globally. And the incidence is higher in males compared to females. For every 100 girls, there are 135 boys. Meaning, if you get 100 girls affected with cerebral palsy, so you get 135 boys that was affected with cerebral palsy. And about one half of children with cerebral palsy are born prematurely. Premature babies, particularly those who weigh less than 3.3 pounds, they have a higher chance of having cerebral palsy than those babies that are fully term. So the other low birth weight babies and also the other multiple births, such as twins and triplets. And more than half of children with cerebral palsy have hemiplegia. That is, one side of their body is paralyzed, typically seen as stroke in adults. And 1 in 9 people with cerebral palsy, they have the picture of autism. That is another form of developmental disability in which the children has social interaction disability. That one is genetic in nature. And 1 in 4 people with cerebral palsy have epileptic seizures. And 6 out of 10 people with cerebral palsy have normal or superior intelligence. And 1 in 3 children with cerebral palsy cannot walk. Then 1 in 4 children with cerebral palsy cannot feed or dress themselves. What caused this cerebral palsy? Actually, the cause of cerebral palsy is idiopathic, that is unknown. But clinical presentation and many researches have shown that it is as a result of damage to the fetal or infant brain. It occurs when there is damage before, during, or within 5 years of birth that prevent brain from developing properly. Brain damage in infancy or early childhood can also lead to cerebral palsy. It doesn't mean that infant people cannot get cerebral palsy. For example, a baby or toddler might suffer damage because of poisoning or lead poisoning, or because of bacterial meningitis, or due to low blood flow to the brain, or being shaken. That is, we call it shaken baby syndrome, or being in a car accident. All these are the risk factors that might cause damage to the brain, which might probably result in having cerebral palsy. Also, the disability affects mothers. It affects mother tongue and movement, but it is not caused by the problems with the muscles or the nerves. It is strictly as a result of developmental brain damage. The common cause of CP are: number 1, bacterial and viral infection. Number 2, bleeding in the brain, that is hemorrhaging. Number 3, lack of oxygen to the brain before, during, or after birth, that is asphyxia. And it can be due to, number 4, can be due to prenatal exposure to drugs and alcohol, mercury, or poisoning from fish, and toxoplasmosis from raw or undercooked meat. It can be due to head injuries sustained during birth on the first few years of infancy. Not every case of cerebral palsy has a clear-cut explanation, as I said earlier. It is estimated that more than 20 to 50% of cases have unknown causes. How can we know that our children have cerebral palsy? That means diagnosis. What are the diagnoses? What are the criteria of diagnosing cerebral palsy? Children with cerebral palsy can present after failing to meet subdevelopmental or failing to meet those expected developmental milestones. The 2003 American Academy of Neurology, that is AAN, has some parameters which suggest the potential risk of having cerebral palsy if there is impairment in any of them. The parameters are mental retardation, ophthalmologic and hearing impairment, speech and language disorders, oromotor dysfunction. These are the parameters of AAN. But there are some criteria of diagnosing cerebral palsy. The diagnosis of cerebral palsy has to begin from the history of gross motor developmental delay in the first year of life. The cerebral palsy frequently manifests as early hypotonia for the first 6 months to 1 year of life, followed by spasticity. Abnormal muscle tone is the most frequently observed symptom of cerebral palsy. The child may present as either hypotonic or more commonly hypertonic, that is, decrease or increase of resistance to passive movement respectively. Children with cerebral palsy, they may have an early period of hypotonia followed by hypertonia. The greater the period of hypotonia before the hypertonia, the greater the likelihood that the hypotonia will be more severe. And then definitive hand preference before 1 year of age is also a red flag possible sign for hemiplegia. Asymmetric crawling or failure to crawl may also suggest cerebral palsy. And growth disturbances obtained noted in children with cerebral palsy, especially failure to trip. The general medical history should include a review of systems to evaluate for the multiple complications that can occur with cerebral palsy. What are the prenatal history? That is, those history before birth. The prenatal history should include information on mother's pregnancy, such as prenatal exposure to illicit drugs, toxins or infections, maternal diabetes, acute maternal illness, trauma, radiation exposure, prenatal care, and fetal movement. And history of early frequent spontaneous abortion, prenatal consanguinity, and family history of neurologic disease such as hereditary neurodegenerative disease is also an important history to be taken. Perinatal history, that is during birth. The perinatal history should include child gestational age, that is the degree of prematurity, Presentation of child and the delivery type it might be due to abnormal child delivery such as breech birth, the birth weight, the ABGA score, that is the ABGA meaning the A for appearances, B for the false, G for the grimace, and A for activity, and R for respiration. These are the score that also determine the cerebral palsy. And complication in the neonatal period, that is intubation time, presence of intracranial hemorrhage on neonatal ultrasonogram, feeding difficulties, apnea, bradycardia, infection, and hyperbilirubinemia. Then developmental history. The child developmental history should review his or her gross motor, fine motor, language, and social milestones from birth until the time of the evaluation. The gross motor milestones concerned with cerebral palsy include head control at age of 2 months, rolling at age of 4 months, sitting at age of 6 months, and walking at age of 1 year. Infants with cerebral palsy may have delayed gross motor milestones or show an early hand preference when younger than 1.5 years, suggesting that the relative weakness of one side of the body that is reaching unilaterally. Physical examination. Physical indicators of cerebral palsy include joint contractures, secondary to spastic muscles, hypotonic to spastic tone, growth delay, and persistent primitive reflexes. The initial presentation of cerebral palsy include early hypotonia followed by spasticity. Then generally spasticity does not manifest until at least 6 months to 1 year of life. The neurological evaluation includes close observation and a formal neurological examination. Then you have to observe the gait pattern. The overall gait pattern should be observed at each joint in the lower extremity, and upper extremity should also be assessed. Let's start from the hip. You might notice excessive flexion, adduction, femoral anteversion, and you might notice scissoring gait. Scissoring gait is the most common spastic cerebral palsy mode of walking. Knee flexion, extension with valgus or varus stress occur. Then foot, characterized by equinus or walking on toe. Varus also of valgus of the hind foot is also the most common feature of cerebral palsy. The gait abnormalities might include the crouch position with tight hip flexors and hamstrings muscles, weak quadriceps, and excessive dorsiflexion. Management. There are many types of cerebral palsy. So therefore, management of cerebral palsy is based on the type. It's according to the features of the. It might be spastic cerebral palsy. It might be attitoid. That means those who have gait impairment. It might be ataxic. Those who have voluntary balance disorders. It might be spastic. It's increased to passive stretching and increased resistance to passive movement. It might be hemiplegia. It might be quadriplegia, hemiplegia, half side of the body is affected, quadriplegia, four side of the body are affected, monoplegia, one side of the body is affected, and many more. Therefore, the management of patients with cerebral palsy must be individualized based on child clinical presentation and requires multidisciplinary approaches. And medical management of abnormal movement, there are many numerous medication, although what to use of now is to target the spasticity, dystonia, myoclonus, chorea, and atitosis. The most common example of drug administered is baclofen. It can be either orally or interarticular. It is often used to treat patients with spasticity. And the best way to manage children with spasticity is with physical therapy. Physical therapy aims at improving coordination, balance, strength, flexibility, endurance, pain management, posture, gait, and overall health condition. Here comes to the end brief explanation on cerebral palsy. And I hope this video will help a lot. And don't forget to give us thumbs up, share, and comment. If you have any query, you can reach me via an email address drjahun@gmail.com or call me +917053005453. Thank you. See you next time.